Good evening, everyone. My name is Dr. Shirin Tofai. As you know, you are joining me for Hernia Talk Live. This is our weekly event, which we call Hernia Talk Tuesdays. We're currently simulcast on Zoom and Facebook Live. You can also catch this recording later on YouTube. You can follow me on Twitter as well at HerniaTalk. Today's esteemed guest panelist to answer all of your questions is Dr. Michael Hibner. Dr. Hibner is a urogynecologist by training. You can follow him on Facebook at michael.hibner. He is a fantastic surgeon, a great human being, but really interestingly, and the reason why I have him on this week is he is one of the very few specialists in treatment and evaluation of pudendal neuralgia, which we will learn about and discuss for the rest of the hour. So welcome everyone to Dr. Hibner. Hi, Michael, how are you?
Hey, how are you, Sharon? Thank you for
Good.
inviting me. I'm really honored.
So for the audience, this is actually the first time I'm seeing what Dr. Hibner. I have known about him and read his work for many, many years. He actually has a chapter on pudendal neuralgia in my book, the Sage's book of hernia, chronic pain and hernias, which is very unique. It's a great, great chapter. I highly recommend that you guys take a look at it. So that was my first kind of interaction. We have a mutual friend, Dr. Jonathan Solnick, who is head of gynecologic, like minimally invasive surgery in Toronto now. He's an excellent surgeon. We used to share a lot of patients, and then I learned about Dr. Hibner. But you're in a different state. You're in Arizona, which looking back there, it looks like it's not that hot. Usually I'm used to seeing Arizona be so hot.
The hottest day in the last 2 weeks. It was pretty cold already, and today is back to like 90s.
Oh, okay.
Just for a day.
So we have tons of people on both Zoom and Facebook, and we'll kind of go through those questions. But before we do that, I want to just get a little introduction of what you do. What does it mean when you're a urogynecologist? How are you different from a urologist, or what we call female urology specialists? And just give us a little bit more information about what you do.
Yes, so thank you. So I am by training, by my residency training and board certification, I am an OBGYN doctor. I do not practice any obstetrics, nor I have ever practiced obstetrics. And right after my OBGYN residency, I did a fellowship in at Mayo Clinic in female pelvic medicine and reconstructive surgery, which is a urogynecology. It is a specialty for that is designed to treat patients with prolapse and incontinence, female patients with prolapse and incontinence. I actually have, after my fellowship, I have actually never practiced prolapse or incontinence, because right after my fellowship, I got interested in treating patients with pelvic pain. So I actually really see patients for a different specialty that I trained for.
Mm-hmm.
And it is the specialty that at the time, 17 years ago, I graduated from my fellowship in 2003. At the time, didn't really exist. When I decided to see patients with pelvic pain, everybody was surprised that that's what I want to do, because honestly, no one really wants, no gynecologist wants to see patients with pelvic pain.
Very difficult.
But I was very persistent, and initially I was seeing patients with endometriosis, because that's what we are taught in gynecology. And very quickly I noticed that there are patients who have conditions that are just not endometriosis. They just don't meet that endometriosis picture. And I was very determined to figure out what is wrong with them. Mm-hmm. Luckily, in 2004, the Google was already very operational, so I started Googling their symptoms. So I actually did what patients do now. That's what I did as a physician. So I Googled their symptoms, and the name pudendal neuralgia came up. And when the name Pudendal Neuralgia came up, I already had a name of the disease, which was very useful.
Wow.
Because then I could take the name Pudendal Neuralgia, and I could go on Medline, which I don't know if all the patients know, but Medline is the online library with medical articles.
Yes.
And when I typed in Pudendal Neuralgia, very few articles came up. But what I noticed is that most of them had one common name. And that name was Roger Robert. Roger Robert is a French neurosurgeon in Nantes, France. So I realized that he wasn't always the first author, but his name was on most of the articles. So I realized that this is the person I need to get to, and this is the person that I need to somehow work with. And I have a friend here. I do speak some French, but not enough to write a letter. But I have a friend here in Phoenix who is half French. I understand that when you write a letter to France, it has to be in French.
Yes.
And so what I did, I had a letter written to him, which I didn't have his email. I had his regular address.
Wow.
So I sent the letter to Roger Robert asking him to Nantes, asking him if I could come and learn from him. And for 2 weeks, I haven't heard anything. And 2 weeks later, I got an email from him in perfect English that absolutely yes. And how about in 2 weeks, I can come and visit him. That was not easy because in 2 weeks, I already had plans. And also we had little children. But I was able to go. And I spent almost 3 weeks with Roger Robert, who we quickly became friends, and I learned everything at that time that I could learn about Pudendal Neuralgia. And
that's fantastic. We should encourage that more often. Really, there are people out there that it's like, for us, it's like we're at Disneyland. It's like a life experience. You go there and you can learn so much. I do that for many of my colleagues, some of them in Europe, that come for a specific need. And I learn from other specialists. Kind of when I do HerniaTalk, it's my way of learning from you all. But that's a great story. That's a great story.
Yeah, so I really like what you just mentioned, because I actually trained at Mayo Clinic from a very great, one of the best gynecological surgeons, Dr. Javier Magrina, and those are his words. Like, if we were done with surgery early, which wasn't too often, but if we were, he would tell me, it's like, don't go home, go to another room, just pick up any OR and go wherever there's surgery and just go there and watch, because you will.
I do that. I do that all the time. When there's downtime in between my operations, I go, some people think I'm like sneaking or poking in there. I'm not. They get all nervous.
Yes.
But I just go there to kind of learn, see what they're doing. We don't necessarily get exposure.
Yeah, and actually, when I do pudendal nerve decompression surgery, most of the instruments that I use are actually ENT instruments. So I actually use a neurosurgical microscope, because the way that I do pudendal nerve decompression surgery, the transgluteal approach, I don't use the Da Vinci robot, I don't use laparoscopy. It's really an open surgery through the incision in the buttock, but one of the modifications, so I actually have significantly modified the surgery from what Roger Robert in France does.
Wow.
And one of the modification was that I use neurosurgical microscope, but most of the instruments are actually the ENT instruments, which took time, because I had to go through the trace, I had to go through, what they use, what instruments they use,
Right.
and none of the instruments are like gynecological instruments. And and actually, in fact, one of the suggestions for the instruments came from the patient, because one of the things when you operate on the pudendal nerve actually enters what's called an Alcock's canal. Alcock's canal is the canal in the muscle, in the obturator internus muscle. So it's a narrow canal. And the patient many years ago asked me, how do you actually see in the canal? And I was thinking, it's like, actually, we don't really see that well. And he actually, was a gentleman, he actually made me think about it. And the next day I went to work and I spoke with my favorite scrap tech. And scrap techs are so knowledgeable.
Yes.
Her name is Cindy. And I'm like, Cindy, what do I do to actually see in there? And she suggested the longest possible nasal speculum.
Yes.
And that works so perfectly. And ever since, I've been using, the longest possible nasal speculum, and that's actually what works.
I mean,
So
nasal speculum is like your speculum, right? The gynecologic speculum.
yeah,
It's
it's
a
just
little
super
bit different, much smaller and longer.
yeah, much smaller and longer. But the point is, that I have modified the surgery, that I actually listened to suggestions of, like, the suggestion came from the patient that
Yeah.
I need something, and the idea of what to use actually came from one of my skeptics. And that happens when you're almost reinventing the surgery that doesn't exist. You have to be very open-minded, and you have to listen to people that actually may know something that you don't.
Yes, agreed.
Mhm.
So many of your fans are already on live. They understand that you have recently switched to private practice. Can you just give a quick blurb? Where's your practice? How could they find you? Are you seeing patients full time now? Give us an update on your practice.
Yes, so for 17 years, I worked at Dignity Health St. Joseph's Hospital in Phoenix, and I left in May of this year. This was my academic practice where I was involved with teaching in medical schools. And in May, I left, and it took me a few months to get organized. But in September, I opened my private practice here in Scottsdale, which is a suburb of Phoenix. So I'm actually still in Phoenix.
Yes.
My practice, hold on, I'm going to come. My practice is called Arizona Center for Chronic Pelvic Pain.
Yes.
So it's AZCCPP. So my website is azccpp.com. And on the website, all our numbers and emails are on the website. I opened the practice end of September, but I'm still getting organized. So of course I'm seeing patients and I'm doing surgeries, but I'm still getting organized as far as the staff. So if you're calling, please don't get discouraged. I am more of an academic type. I'm not a business person, so it's taking time for me to learn all the ins and outs of the practice or running the practice.
And even though you're a gynecology trained, for pudendal neuralgia, you do treat males and females, correct?
Yes, correct. So actually, thank you so much for bringing this up, because I initially saw male patients until 2012, from 2005 until 2012, and then American Board of OBGYN said we can't. We stopped seeing patients. They reversed their ruling, but my institution did not allow me to do that. And now when I'm in practice, I do see male patients. And actually, as it is right now, I would say, since I started, I would say about half of my patients are actually male patients, because male patients can get pudendal neuralgia just like women can get pudendal neuralgia.
And, is the anatomy different?
No, the anatomy, I mean, once you get to the nerve, it looks pretty much the same. The surgery in male patients is a little bit difficult. And the reason why it is a little bit more difficult than in women, because when you cut through the buttock, you have to cut through, well, actually I don't cut, I spread the fibers of the gluteus muscle.
Yes.
And males tend to have a thicker gluteus muscle. Like even the guys that are not very muscular tend to have so the nerve is just deeper. So once you get to the nerve, it looks the same, but you're basically working in the deeper area to get to the nerve. And that makes it a little bit more difficult. And I actually, and someone asked me that question, I think a few days ago. Of course, I'm a gynecologist really by training, and I feel very, very sorry for women that are in pain. And that's really my first, goal, is to take care of women. But I really feel really bad about male patients, because I feel that guys have really nowhere to go, because for women, there are gynecologists that take care of pelvic pain. There's not that many, but at least there's somebody to talk to. For guys, there's often nobody to talk to.
Yeah, I agree. And it's such a terrible, usually most diseases have a name that describes the reason for the problem, like pudendal neuralgia, nerve pain from the pudendal nerve. But this term chronic pelvic pain has always bothered me, because it's like a miscellaneous. It could be anything. It could be a hernia. I see tons of people with that have been labeled as chronic pelvic pain and they have a hernia. I fix the hernia, pain goes away. Or they could have something super complicated like pudendal neuralgia. So on that note, can you give us just a brief discussion of what is pudendal neuralgia and then how do people know if they have it?
Sure, of course. That's a really good question, and you know, for our listeners, when you talk to different providers, they actually may have a different term of what pudendal neuralgia is, my term may be different, or what I call pudendal neuralgia may be different from other providers.
Okay.
So what I do is I actually strictly separate the term pudendal neuralgia and pudendal nerve entrapment. Just to keep it separate and to keep it clear. So for me, at least in my practice, pudendal neuralgia is pain in the area of the pudendal nerve without necessarily saying what the cause of the pain is. So if someone has pain in the area of the innervation of the pudendal nerve, and I would call that pudendal neuralgia, but I am not necessarily saying that their pudendal nerve is injured. And the reason I do it that way, because it is very difficult to actually know if the nerve is injured or not, because there's really no good test that I can do to find out if the nerve is injured. Now, pudendal nerve entrapment is if the nerve is injured either by scar tissue, suture material, mesh, tumor, compression, external compression, or anything else.
Yeah.
So pudendal nerve entrapment is going to cause pudendal neuralgia. But there are other causes of pudendal neuralgia. And for example, if someone has like severe pelvic floor muscle spasm,
yes,
they are going to have symptoms of pudendal neuralgia, because if someone has severe pelvic floor muscle spasm, those spasming pelvic floor muscles are going to put pressure on the pudendal nerve, and they're going to have the symptoms of pudendal neuralgia.
So that's because the nerve starts in the back, as all nerves do from the spine, and then it runs through the pelvic floor muscles. So any pelvic floor spasm can potentially poke or irritate the pudendal nerve that's running through it, right? And
yes. So there's that. So yes. So there's that area of the pudendal nerve that runs through what is called the Alcock's canal. The Alcock's canal, like I mentioned, that's a part of the obturator internus muscle, which is one of the pelvic muscles. And when pudendal nerve runs through the obturator internus muscle, there's a fairly tight canal, and when the muscle is spasming, it is going to put a pressure on the nerve. Okay. And so that patient has a pudendal neuralgia, but that patient doesn't really have a pudendal nerve entrapment, because the treatment for that patient would not necessarily be to operate on the nerve. The treatment for that patient would be to somehow relax the muscles, whether, you know, and there's many treatments that can be done for that.
And what are the symptoms of pudendal neuralgia? There's so many branches from it. What are the different symptoms?
So there is, so it is the pain in the area of the pudendal, in the innervation of the pudendal nerve, which in women, it's labia, clitoris, vagina, perineum, and the rectum. And in men, it's perineum and the rectum, penis, and scrotum. So not testicles, but scrotum. And the pain is generally much worse with sitting than with standing or laying down.
Okay.
And generally the pain is better when sitting on the toilet versus sitting on the chair, because that center of the pelvis is elevated in the air.
Like a donut. Yeah.
Like a donut, yes. So this is the biggest symptom. And there's something that is called Nantes criteria. So Nantes is the city in France where Roger Robert works. That's the guy that I learned from. And so they came up with an inclusion criteria, exclusion criteria, and complementary criteria. So the list is very long of those criteria. I don't necessarily agree with everything that Roger Robert published. So even though he's my mentor, I still don't agree with everything. because, for example, he states that in pudendal neuralgia, pudendal nerve entrapment, there's never pain at night when the patients are sleeping. Well, that's not necessarily true, because if someone has an entrapped nerve by pelvic mesh or the suture,
Yes.
they're going to hurt
Right.
regardless whether they're laying down or sitting down. So I think that the criteria really need to be modified.
They're talking about probably primary pudendal neuralgia, where the nerve itself, like a cyclist, right? Is that
Yes.
the most common? It's like a cyclist. They're on that small little horrible, painful
So you know,
cycling seat.
this is
Two
actually
little areas are always being pushed on.
Yeah, so this is the question. Yeah, especially like the race seats, which are really narrow.
Yeah.
So this is actually the question that I get asked quite often, because patients are like, well, I don't ride the bikes. So this is where the misconception came from. So pudendal neuralgia, for the very first time, was described by a French physiatrist and neurologist, Gerard Amarenko, from Paris in 1980s. And he noticed that there is this pain that he didn't know what it was, that happens in cyclists and bikers.
Mhm.
And there's a lot of them in France. So he called that syndrome du cycliste, the cyclist syndrome,
Yeah.
because at that point, he didn't really know if it's a pudendal nerve, if it's any other nerve, if it's a muscle, or whatever it is. So he called it the cyclist syndrome because he noticed that it happens in cyclists. Later on, he figured out that it's an injury to the pudendal nerve, because what happens when you sit on the narrow bike seat,
Yes.
the bike seat presses against the sit bones. I mean, medically we call it ischial tuberosities, but most of the people call it sit bones. And the nerve travels on the inside part of those sit bones.
Mm-hmm.
And so there's this misconception that pudendal neuralgia mostly happens in cyclists. But that's not true. I mean, it happens in cyclists, but there's many other ways to get it that I believe are actually more common than riding a bike.
So I read back in, I think, World War One. Did they have Jeeps in World War One?
Jeep started in World War II, but they had
World War Two.
Yeah.
The soldiers were sitting on their seats, but there were no cushions on the seats.
Yes.
They would jump up and down,
Yes.
and they would get pudendal neuralgia.
You know, I read something like that, and at that point, of course, they didn't know that, but of course, sitting on the hard surfaces, yes, I have many patients that have developed it from sitting on the hard surfaces. Actually, people that have like prolonged sitting, just sitting for many hours, because it puts pressure on the nerve itself. So cases where I've had patients that like took a long like flight to Japan, or you know, for many hours, where they were stuck in the seat and never got up, and there may be like some ischemia to the nerve just from like sitting in an uncomfortable position. And I definitely have patients that took like a long car trip, you know, across the country, or were sitting on the hard seat. So yes, absolutely.
Maybe all these Zoom meetings we're doing, you're going to see an increase in pudendal neuralgia.
Well, I guess we'll know. That's a very good point. You know, I also, and that is before COVID times, I had a group of patients that were like attorneys or engineers. I mean, those are the people that tend to sit. You know, luckily for us, the surgeons, I mean, even if we do like the robotic surgery, we still like get up and, you know, walk. But some like attorneys, they sit for hours and hours and hours in their positions and stuff. And so, yes, I think there are more people.
It's not good for your back anyway. You should get up and stretch every hour or so. Let me ask you this. So when you get it because of like prolonged sitting, do you see it mostly in like really thin patients or cachectic patients? I've seen them in like super thin patients, and I've also seen it in patients that are wheelchair bound.
Yes, you know, that's a great observation, because I totally agree. I think people that are super thin, they have less of the padding of the fat.
Yeah.
And I think they're more likely to get it. So that's one thing. But there is another observation that actually My previous physical therapist, Loretta, who was in my office, and Loretta was this super brilliant, observant physical therapist. She retired, but she made, and we actually, Loretta and I used to go to the cadaver lab, and we made some observations in the cadaver lab. And one of the observations is so it's different when someone had surgery and they had mesh, because a big part of my practice right now are patients that, for example, had prolapse or incontinence and they had some kind of a mesh and that injures the nerve. So that's a separate category.
Yeah.
But I think there are people that are anatomically predisposed to pudendal neuralgia, and the area where the nerve most commonly gets entrapped is the area where two ligaments in the pelvis cross, or they actually come close to each other. That's the sacrospinous and sacrotuberous ligament.
Yeah.
And different people have different space, or that width between the ligaments.
Yes.
And I think people that tend to be thin and tall, so for example, for women, that would be more of a boyish type of the build of the pelvis, like slim, like small pelvis, tall.
Narrow pelvis, yeah.
Yes, narrow pelvis. They tend to have that space narrower. So those are the patients that space is narrower, so the nerve is probably more likely to get entrapped. The good thing about it is that those are also the patients that are easier to do the surgery, because they have less fat and the nerve is more superficial, so it's easier for me to get to. But they have less padding, definitely.
So when you're treating these patients, do you try to figure out, do they present with every single part of the neuralgia? So in a female, they get clitoral, vaginal, labial, perineal, and perianal pain? All of it?
No, they can have all of it, or they can have more of a selective one branch pain.
Okay.
Generally, patients that have all of it, at least we think, I don't know if it's really, we have good research to prove it, but I think those patients tend to do better because it's easier to surgically decompress the whole trunk of the pudendal nerve rather than the branches.
Yes.
But there are definitely people that have selective branches of the nerve that are compressed.
Got it.
And so just the anal pain or just the clitoral pain. And actually for that reason that you just mentioned, a few years after I went to France, I actually went to Austria to work with another surgeon in Austria, Dr. Oskar Aschmann, who is doing dorsal clitoral or dorsal penile nerve decompression. So those are patients that have selective pain either in the clitoris or the penis, where you can actually selectively decompress just that one branch of the nerve.
Interesting.
And in those patients, the incision is in the different area, and it's a different surgery.
So can you have, so the nerve starts at the back and comes forward. So can you have anal pain without the penile pain, or penile pain without the anal pain, both?
Yes, correct. You can, because the nerve can be compressed in different areas. So what I do for those patients, and that's something that actually I came up with, because when I went to France, the Professor Robert only did one kind of surgery. When I went to Austria, Dr. Aschmann only did the other kind of surgery. Now I had a dilemma: how do I decide which type do I do? So I came up with an idea, and me and my coworkers, we came up with an idea of doing a selective nerve block. So we came up with the techniques where, using the ultrasound, I can selectively block one of the branches of the nerve.
Wow.
Perineal branch or clitoral branch. It is a little bit more difficult to block the rectal branch. But radiologists can generally do that with a CT. And this way it allows me to distinguish which of the surgeries do patients need, depending on which branch do I block.
Okay. One of the questions is there a connection between pudendal neuralgia and proctalgia fugax? Can you explain that?
Well, so I think proctalgia fugax is one of those conditions that So I think proctalgia fugax, what it really is, it's the spasm of the pelvic floor muscles, and it's a condition that has multiple names. So that's something that I used to call spastic pelvic floor syndrome. Uh, uh, um, uh, Actually, I used to call it pelvic floor tension myalgia. Now I call it spastic pelvic floor syndrome. Some people call it vaginismus. They call it proctalgia fugax. They call it levator syndrome. Yes, there is a connection because patients with injured pudendal nerve, they will have the spasm of the pelvic floor muscles almost always. When you have an injured pudendal nerve, you will almost always have spasm of the pelvic floor muscles.
Got it.
So whenever you have a bowel movement and the pelvic floor muscles are stretched, it is extremely painful. Now, most of the patients.
Sorry, proctalgia means anal pain, right?
Yes, yes.
So proctalgia fugax, it's kind of like any anal pain.
Yes, so.
That no one can figure out.
Yeah, no one can figure out, but I think if you actually examine those patients, you would find that a lot of them actually have the spasm of the pelvic floor muscles. And I know fugax means, because proctalgia is anal, but fugax means that it just comes and goes like without any good reason. But I think if you figured it out, like if you talk to a patient, that a lot of times it is somehow related to stretching those muscles or putting some kind of a pressure on those muscles. So I think my first thought in those patients would be to actually look into spasm of the muscles and make sure that this has been ruled out before like doing anything else.
Got it.
So
but not a nerve pain, but a muscle spasm issue.
So generally with all the patients that have pudendal neuralgia type of pain, and again, I'm trying to separate pudendal neuralgia from pudendal nerve entrapment. So if they have pain in that area, whether it's proctalgia fugax, whether it's vaginismus, like whatever you call it, the first thing that I do in patients is to make sure that pelvic floor muscle spasm is not what is contributing to the pain.
Yeah, got it.
The way I do that is I do send patients for physical therapy. I am a huge proponent of Botox. So I inject Botox vaginally, I inject Botox into the anus, I inject Botox into adductor muscles in the legs, piriformis muscles, because once I eliminate muscle spasm and patients are still hurting, I think that's the time when I can comment on the nerve injury. I think as long as patients have significant muscle spasm, I think it's very difficult to assess their nerves because you just don't know.
Yeah, primary versus secondary issue.
Exactly.
Okay, you talked about pelvic floor mesh and how that can potentially injure the pudendal nerve. So two questions on that. How is it that pelvic floor mesh can injure the pudendal nerve? Because the pudendal nerve is not exposed where it's placed. And then secondly, we have a live question, which is, what do you recommend if a patient's pudendal nerve is caught within the scar tissue of the pelvic floor or somehow pelvic floor fascia? What do you do for that?
Okay, so the first question. So it depends on the type of the mesh. So there are, and I actually just last week gave we had this big conference and I gave a big webinar to the physicians on how mesh can entrap the nerve. And it really depends. There are different meshes that attach to different parts of the pelvis, because when you place the pelvic mesh, it actually has to have an attachment point. And so there are meshes. So there are meshes that attach to what is called the sacrospinous ligament. That's one of those ligaments that I mentioned where the pudendal nerve is traveling nearby. And I have multiple patients where the mesh went deep into the ligament, or it went a little bit too lateral, too much to the side in the ligament, and it actually directly injured the mesh. So, and I have videos of that where the mesh is actually piercing right through the nerve. Like if this is the nerve, the mesh actually pierces right through the nerve. So there can be absolutely a direct injury to the nerve. So that depends on the type of the mesh. The second way that, in my mind, that the mesh can do it is if, for example, mesh is placed into the obturator muscle, obturator internus muscle, that muscle will start spasming
Yes.
And just like I mentioned, because the nerve actually travels through that muscle, when the muscle spasms around the nerve, it will give the symptoms of pudendal neuralgia.
Yeah.
So it is
So what
very,
do you
very
do? So you just have to remove the mesh,
correct.
and
So
then can't the scar tissue from that operation then also cause pudendal neuralgia?
yes, so what I do is, when I have a patient that had a mesh and now developed pudendal neuralgia, like I really study the operative reports and try to figure out what mesh the patient had, and then most of the cases I would recommend removal of the mesh.
Mm-hmm.
Once I get to the nerve and I actually decompress the nerve, I wrap the area of the decompression with something that would prevent the scarring of the nerve.
Like Interseed?
No, some people use Interseed. I actually used to use something that's called Neurogen, which is a nerve conduit. It is
Oh, okay.
a collagen tube that is actually made specifically for nerve repairs. But a few years ago, I switched to something that's called amniotic. So amniotic is an amniotic membrane.
Yeah.
And the amniotic membrane is actually very beneficial because it has nerve growth factors, and it also has chemicals that attract your own body's stem cells. So you repair the nerve, you wrap it with amniotic, and then your own body stem cells are attracted to that area of the nerve to promote the repair of the nerve.
Yeah. Got it.
So the second question is, I partially answered it. If the nerve is entrapped in the scar tissue, in majority of patients, I can surgically decompress the nerve. So that's the procedure, that's the neurolysis. So I go in with a surgical microscope at the high magnification. And like I mentioned earlier, I use ENT instruments. So they're small, tiny instruments. And sometimes depending if there's a lot of scar tissue, it may take hours. And one fiber at the time, I basically cut out the nerve out of the scar tissue. And once the nerve is free, I know those are very, sometimes those are very time-consuming surgeries depending on the amount of scar tissue.
Yeah.
That actually is not the most
difficult area.
It is, and that actually, once you find the nerve, cutting it out of the scar tissue is not the most difficult. What is the most difficult is actually to find the nerve in the first place, because you're cutting into the bottom, and you're looking for a needle in the haystack.
Yeah.
To actually find the nerve if it's scarred. Once you find it, it just becomes easy.
Yeah.
But I do have devices that allow me to find the nerve. So I have this, something that's called the NIMS monitor, Nerve Integrity Monitoring System. So it's an electrical device that when I touch the nerve, it sends the electrical signal and it beeps. So I have a wand and I basically start touching in the area. And once I touch the nerve, it's kind of like the guy on the beach in San Diego looking for metal, like I'm walking with, and once I find it, I'm okay, the nerve is somewhere here.
That's pretty funny.
Yeah.
Have you seen that this pudendal neuralgia is also associated with other chronic pain problems such as interstitial cystitis?
Absolutely. So I think those conditions absolutely tend to go together. So, interstitial cystitis is actually one of the other conditions that I commonly see patients for.
Yeah.
But and I'm sure a lot of people are aware that interstitial cystitis is like no one really knows what it is. No one really knows what causes it.
Right.
And we don't really know how to diagnose it. So if you talk to a lot of urologists or urogynecologists, we all have our ideas about interstitial cystitis.
Yeah.
So I believe that interstitial cystitis is a condition that is actually primarily caused by spasm of the pelvic floor muscles and patients' inability to empty the bladder. The bladder becomes irritated because you constantly push to urinate. So if you have pudendal nerve injury, you develop pelvic floor muscle spasm, and then you have what we call medically obstructive voiding, meaning you sit on the toilet and you can't go. So patients are pushing to empty the bladder. And when they do that, the bladder becomes irritated. So that's how interstitial cystitis goes together with pudendal nerve injury.
So the issue I have, which Tracy shares on this, she says hi.
Hey, Tracy.
She brought this up too on Facebook, is I see patients with like they already have 5 diagnoses. They've been told they have pudendal neuralgia, interstitial cystitis, they have
IBS.
endometriosis. None of these proven, by the way. These are always kind of like these diagnoses thrown at them. Nerve entrapment, can't tell you what nerve, but you have nerve entrapment. They get spinal nerve stimulators, all of these things. In my case, they end up having a hernia because hernias can give pelvic floor spasm. They can cause urinary frequency because of it, as well as some tenesmus, which is like rectal anal pain, and feeling like you have to void, but you don't. But it's all secondary to pelvic floor spasm, which is due to the hernia. You fix the hernia, it goes away. They've been told they have obturator neuralgia, they have obturator nerve problems. And so I have a little bit of issue with it because I feel these patients are just, every diagnosis thrown at them: chronic fatigue syndrome, Lyme disease, that's a big one in California. We don't even have ticks that cause Lyme disease, but everyone's got Lyme disease. So what do you feel about that? Do you see that too? You must see a lot of that.
So, just to give you an example, I mean, it's a perfect timing. I saw a young patient today. I actually have seen her before at St. Joe's and in my previous practice, and she came back. And so she actually has proven endometriosis, known endometriosis.
Yeah.
She has scar tissue from years of endometriosis. She has IBS. Oh, she was told she has IBS.
IBS.
Yes. She was told she has IC and interstitial cystitis, and she probably does because her bladder hurts as it fills up. So that's by definition, when the bladder hurts, when it fills up. She has really bad muscle spasm because I can feel it. And so I told her she has all these things. So she's like, oh, and I said, listen, I don't want you to get upset because all of the things that I have mentioned to you can be explained by one thing. So it's not that you're so unlucky and, like everything in your life is just super unlucky, but you got endometriosis because 10% of women have endometriosis. Like your endometriosis was worse, but it's a common condition. You got endometriosis that led to your pelvic floor muscle spasm. And that pelvic floor muscle spasm gave you an ability to empty the bladder and the bowel. So your bladder became painful and your bowel became irritated. And so I said to her, you have a common condition and you probably have all these things, but it doesn't mean that it's like the end of the world. Yeah. You probably need to fix your endometriosis and we need to fix your pelvic floor. I need to remove your endometriosis scar tissue. I need to give you Botox and send you to physical therapy.
Yeah.
And give you some suppositories that I am a great believer that Valium, baclofen, ketamine suppositories help relax the muscles. And your IBS, your interstitial cystitis, is probably going to get better. So it is not that. So I mean Lyme disease. That's and chronic fatigue. So what happens? And she was actually a perfect example. That your question was, you asked it at the perfect time because that's someone that I saw like a few hours ago. So young woman, she's 29. She gets up to urinate to the bathroom 6 times every night. Guess what? She is really tired because she doesn't sleep.
That's right.
So I can fix her chronic fatigue, not even by giving her a sleeping pill. I can fix her chronic fatigue if me and physical therapists, if we relax her pelvic floor and she can empty her bladder before she goes to bed, then she's going to sleep the entire night.
Yeah.
But she goes to bed with a full bladder because she never empties it.
Very good point. I just feel that a lot of diagnoses are thrown at patients that they get so lost. They don't know who to see, what to do. And then many get unnecessary procedures like these nerve stimulators that are implanted that never address the main problem. Quick question, if you can just quickly talk about the difference between pudendal neuralgia and obturator nerve problems.
Yes, so I do see patients for both. I do take care of both. There are different nerves. Pudendal nerve innervates, like I mentioned, innervates the perineal area, the labia, vagina, clitoris, penis, rectum. The obturator nerve innervates the inner part of the thigh,
Yes.
mostly that part above the knee. And there are different ways that those nerves get injured. So the obturator nerve, well, obturator nerve is in your territory. I mean, the obturator hernias, and
Hernias, yeah.
that's something you could probably talk a lot about. But in gynecological patients, the obturator nerve may get injured in several ways. So it may get injured with some types of the meshes. So it's the transobturator meshes. So there's a certain types of the meshes that they attach to the very near the obturator nerve, and
Mhm.
the nerve may get injured. The obturator nerve may also get injured in patients that have lymph nodes removed during gynecological cancer surgery, because those lymph nodes
Okay.
are around the operator nerve.
Yeah.
So those patients generally have pain on the medial part of the thigh, in that area above the knee. They may also have some motor deficits, meaning they may have like difficulty bringing their legs together, because, but it's generally more of a pain than motor deficit.
Yeah.
And depending on the nerve can be blocked also, just like the pudendal nerve. The nerve block is more difficult than the pudendal nerve, but it can be blocked, because you want to block the nerve and you want to make sure it's the obturator nerve, not the genitofemoral nerve, because there's many other nerves in that area. And it's also important to know that there's an overlapping innervation. So
Yes.
in that groin area, there's many nerves that may go to the same spot. So before you start operating on the nerve, you want to know which nerve to operate on. So the genitofemoral nerve goes to that area, obturator
Yeah.
nerve goes to that area, and that's kind of what you want to do. And both nerves can be addressed either surgically or with injections, but they're completely different nerves. They get injured in different ways.
When you do your injections, I know there's two different ways to do it. There's an anterior and a posterior approach to doing it. Like my pain management people, they're comfortable doing the posterior approach through the buttock area, but the female urology surgeons, they do an anterior approach for the pudendal nerve. Does it matter? Does the injection response kind of give you the diagnosis? Give me a little bit more information
So,
about pudendal nerve
so, so
blocks.
what I do is I actually do two types of the pudendal blocks, not depending on the approach, but depending on the intent of the block.
Mm-hmm.
If I do the block to diagnose the pudendal neuralgia,
Yeah.
historically, I send them to radiology to do it with a CT through the buttock.
Okay.
And the reason for that is that I believe that if I'm going to use that information to decide on someone's surgery, I want to make sure that it really went right next to the nerve. If the and those are the ones that are done with the steroids, and are again done in the radiology.
Okay.
If I do pudendal nerve block with an intent of providing pain relief for the procedure, so for example, I do some kind of a procedure in that area, and I want patient not to have pain for hours after surgery, then I do it through the vagina. Um, so for example, when I do Botox injection, I do pudendal nerve block because I want the patient to be numb for a few hours. Now,
Got
having
it.
said
Okay.
that, I had a patient, several patients that actually wanted me to do that, where I did a transvaginal pudendal nerve block where I added a little contrast to this. And after doing the transvaginal pudendal nerve block, we actually put a patient in the CT scanner, and the location of the block was exactly in the same spot if it was done with a CT. So I honestly don't think it makes much difference.
So if you do a pudendal nerve block and the pain 100% goes away, that's you have your diagnosis. Is that correct?
Well, so this is one of the non-criteria. So, but I think it is very misleading, and I think actually part of it is that the way that it was translated from French initially was kind of very misleading. So
Mm-hmm.
I actually wrote a couple book chapters on pudendal neuralgia, and I did my own translation from French where I tried to correct the misleading thing. If you have pain in the pudendal area and you do the pudendal nerve block, and the
Mm-hmm.
pain goes away, it doesn't mean that the nerve is injured. It just means that the nerve is involved in pain. So
Got it.
this is what I tell patients. And I know this may sound brutal, but sometimes that's the way to explain it to patients. If someone kicked you in the perineal area and you were hurting, and someone gave you pudendal nerve block, you wouldn't be feeling that pain. It doesn't mean that your pudendal nerve is injured. It means that the pudendal nerve is involved in the pain transmission. But it is very important to do the block because there are patients where you have pain in that area, you do the pudendal nerve block, and the pain doesn't go away, like, right after the block. So that means that the pain is somewhere from like a different nerve than the pudendal nerve.
Okay.
So that patient is actually not a candidate for surgery. And that patient, you need to look further and kind of try to figure out what else may be hurting.
And in those patients, you would do it for the buttock because it gets the most proximal, the largest branch of the pudendal nerve. So we'll get all the branches downstream as well.
Well,
Right?
that's one. But the other thing, when you do it through the buttock with a CT scanner, you also have proof that, because you see it on the picture, that it was done correctly. Because if you do the block and the patient doesn't have any relief, then you're wondering, well, maybe I just didn't do it right.
Okay. We have two kind of technical questions. So when you do your ENT scope kind of method to open up Alcock's canal, which is the canal, the bony canal through which the pudendal nerve runs through, do you unroof that canal? And does your operation in any way provide any risk of pelvic instability?
Yes, so those are actually, I'll answer those questions separately because they're
smart people I have online asking all these questions.
I love it. The problem with me is I like to talk a lot, and because Pudendal Neuralgia is really my.
You have 9 minutes. You have 9 minutes to discuss. Actually, I have one case, so give me like 2 minutes or 3 minutes at the end to run.
Okay, so I'll be very quick. So I used to unroof the canal, but honestly, after doing hundreds of those surgeries, I realized that majority of the compression is at where the ligaments cross. So I kind of take a look, but I very rarely see that there is any compression there. So I generally leave it alone because I don't want to be adding to the scar tissue. Because it's not that easy to wrap the nerve in the Alcock's canal, but I can very easily wrap it where it's crossed. So I look, if it looks fine, I leave it. But I used to unroof it, I don't do it anymore. The second thing, the instability of the pelvis comes from cutting the sacrotuberous ligament. And majority of people that were doing that surgery were cutting it and leaving it cut and not putting it back together. So I am the first person, after I returned from France, from learning from Roger Robert, that I decided to actually bring and fix the ligament together. And luckily my uncle is an orthopedic surgeon, so I actually called him before my first surgery and I said, hey, how do you fix the ligaments? Like, tell me, because Roger Robert doesn't do that or didn't used to do that. And my uncle explained to me how to like bring the ligaments together. So I started fixing the ligament from my very first patient. And my patients never develop, at least her physical therapist who examines them, have never developed pelvic instability because I do repair the ligament.
So there is a risk, but only if they do that. That's fascinating.
Yes, very fascinating. If you do not repair the sacrotuberous ligament, yes.
We had a story that came in. I'm going to read it to you. It's a bit long, but I'm sure many people can relate. So this is a patient, female. She was diagnosed with pelvic floor dysfunction a year ago. She was told that her sphincter was in constant spasm and she had pelvic muscle tightness too. She had Botox, trigger point injections, pudendal nerve block, ganglion impar. None of this helped. Okay, so pelvic floor dysfunction, sphincter in spasm, pelvic muscles in spasm. She did a PT and was given muscle relaxers. 4 months ago, things changed. She noticed the pain become more severe. She could barely sit down. And now she has constant shooting, stabbing, burning pain under her coccyx, which shoots into her pelvis and down her left leg. Could this be pudendal neuralgia? She's been referred to pain management for pulse radiofrequency. Coccyx pain is a difficult one. What can you tell us about this patient and also?
Yeah, so let's get the coccyx pain out of the way. So so this is how I. There probably are many other reasons for coccyx pain, but in a patient like that, generally what happens, this is how I explain it to the patient. With pelvic floor muscles, there are many different muscles, but one of the biggest muscle is the pubococcygeus muscle. It runs between the pubis and the coccyx.
The front of your pelvis to the back of your pelvis, basically. Correct. To your tailbone, yeah.
Right. So when that muscle goes into spasm, what it does, it pulls on the coccyx. So often the coccyx pain is actually from the pubococcygeus muscle pulling on the coccyx. So the front of your pelvis to the back of your pelvis, basically. Correct. So when that muscle goes into spasm, what it does, it pulls on the coccyx. So often the coccyx pain is actually from the pubococcygeus muscle pulling on the coccyx. So and
Exactly.
it still like hurts my coccyx to see that some patients get like their coccyx removed for that pain,
Oh,
because what those patients generally need is really good physical therapy and Botox into the pubococcygeus muscle, and
okay.
that generally helps.
Yeah, this does
So,
not sound like a nerve problem. It sounds like it's very muscular.
correct. So in this patient who asked the question, well, one thing that is missing from here, what is really important is, number one, how did the pain start? To me, this is the single most important question, because the pudendal nerve entrapment does not just happen. You don't just like wake up one day and have pudendal nerve entrapment.
Yes, and this is such an important point. You don't just entrap a nerve. Like you don't wake up one day. I see that all the time. Oh, I have entrapped nerve. How?
No,
No surgery, no trauma.
yeah.
Yeah.
So what I call it is, you have to have a trauma to the pelvis, and by trauma, and I'm not saying it in the negative, because there's a negative connotation to the word trauma,
Yes.
but by trauma I mean surgery can be, because surgery is a trauma
Yeah.
to the pelvis in a way.
Sure.
Childbirth could be a trauma to the pelvis.
Mm-hmm.
Athletic activity could be a trauma to the pelvis, like gymnasts.
Yeah.
You know, and then there's like a true trauma, like accidents, etc.
Yeah.
Number two, I believe that people that have a true entrapment of the nerve, most likely they have it on one side. Because again, and I gave this example again to the patient today, a different patient today, and I say, it's very rare that your nerve is entrapped on one side. What are the chances that it's entrapped on both sides?
Right.
So when the patient has pain on both sides, the chances that his or her nerves are entrapped are almost none.
So when they have clitoral pain or penile pain, it's on one side of the clitoris or one side of the
So
penis?
patients can actually tell. Most of the times they can tell. And I think if the pain is on both, and even if they can't tell, you examining the patient by, so there's something that's called a Canal Sign. Well, Canal Sign is really with a facial nerve, but when you press by the ischial spine where the nerve actually travels,
Yeah.
patients say, you know, you can elicit that pain. You can make the patient hurt. So you do that on one side, but they don't hurt on the other side.
Yeah.
And so if the pain is bilateral, and if they don't really have a traumatic event, the chances that the nerve compression, the second are very low. The
Yeah.
second thing to the answer for that question, what this patient didn't say, and that's actually really important, the patient is strictly on the left side. The second thing is, patient had a Botox injection. And what is very important when the patient has Botox injection is that the patient has to go back to the physical therapist, because the physical therapist has to make sure if the muscles have relaxed. Because if the muscles have not relaxed after Botox,
Mm-hmm.
that means that either the patient didn't get enough Botox,
Yeah.
or it didn't go in the right spot. Uh, um, or
Yeah.
the Botox didn't go in the right spot. And so if the patient still has a spasm, I would say try more Botox. But if the spasm is gone and the patient still has pain, and the
Mm-hmm.
pain is on one side, I read it
Yeah.
here.
Pain's on the left side.
Yes, then there is a possibility that it is a pudendal nerve entrapment. It really depends what caused the pain. Radio frequency is one of the options. We stopped doing radio frequency of the pudendal nerve because we had some patients, I had some patients whose pain actually got worse after radio frequency.
Mm-hmm.
Probably cryoablation is a better procedure, but generally the outcomes of both are not that great. Maybe about 25% of patients get better.
So you're saying she may have pudendal neuralgia
You know,
on one side causing the pelvic floor spasm. Could the pelvic floor spasm cause the pain going down her left leg?
um, so
Can you
so
get sciatica from pelvic floor
So
spasm?
there are two explanations to that. So if there's a true nerve entrapment,
Yeah.
and again, it depends on the mechanism, like what happened, how did that pain start in the first place? But if there's a true nerve entrapment, the pudendal nerve and the sciatic nerve, they actually start in the same spot in the spinal cord.
Yes.
It's called the onus nucleus. And it's very common that patients with pudendal nerve entrapment will have the sciatica type of pain. So the pain will go in the back of the leg all the way down to the foot. And
Wow.
that's not uncommon. And of course, if the patient has significant spasm of the pelvic floor muscles and other muscles in the pelvis, like for example, piriformis muscle, then that would put the pressure on the sciatic nerve. because the sciatic nerve runs right behind the piriformis muscle.
Yes.
And in a lot of these patients, they actually have piriformis syndrome.
Yeah.
Yeah.
Yeah. So this lady needs to come see you, sounds like, because this is not something that can just be randomly treated by someone who doesn't specialize. It sounds very complicated.
Yeah, I mean, so it is absolutely, it is very important. So, you know, the question is, for example, I mean, there's many more questions I would need to ask that patient. For example, if when she had a pudendal nerve block, did she have a temporary relief of pain? Super important. When she had a temporary relief of pain, did her leg pain, like even for a few hours?
Yes.
Then the questions from a physical therapist that examines her, because, you know, I'm a surgeon, I'm not a physical therapist, so I don't really examine the muscles, but does she have a lot of piriformis spasm? Because what I would do in a patient like that, and I do that a lot, is to actually inject Botox into the piriformis muscle. I do it with like the ultrasound, and that takes off the pressure of the sciatic nerve.
I may have to bring you back for another session of HerniaTalk because our time is up, but I'm still learning and there's more questions.
I know.
We can't answer them. I'm so sorry.
I would love to talk more and, you know, answer all the questions. I'm sorry I get so passionate that I just like talk so much.
I love it. I love it. I know we had a whole session last week with just me talking and questions after questions were coming, and I eventually had to shut it down because I had to leave. It was actually my birthday.
Oh,
but thank you.
And the beautiful flowers.
You know, thank you. From a grateful patient. Very nice. But you know, what happens is I could have probably gone for another couple hours if I wanted to.
Yeah.
Okay, so on that note, thank you for your time. I know that your time is also precious and to be with your family, and you work very hard.
Thank you.
I'd like to just end this all with thanking everyone who participated. Thank you for all your great questions, very insightful. I learned a lot. Thank you to Dr. Michael Hibner. Follow me on all my social media platforms at HerniaDoc on Twitter and Instagram, at Dr. Tofi on Facebook. And sometime tonight, I will post the culmination of this hour on YouTube so you can watch it and share it with your friends. Thanks again, and everyone have a great evening.
Thank you.
Thank you very
It
much.
was so nice meeting you.
Seeing you.
Not in person, but like the closest we got to meeting in person.
Yes, one day we will see each other.
Oh, absolutely. Thank you. Wonderful.
Take care.
Thank you so
Take care.
Bye-bye. Good night.